Well, good morning, and thank you for joining us for today's session, a closer look at the Quality Payment Program Proposed Rule for 2019 Year 3. I am Sandy Swallow, your host for today's webinar, and I'm flying solo today. Due to an unexpected personal situation that came up, Michelle is unable to be with us. She said to tell everybody hi, and she'll be back in the office in just a few days. Normally, Michelle and I like to tag team webinars such as this. It kind of breaks up the monotony for you folks when there's a lot of details and dry material. So you're going to have to bear with me today as I move through the slides rather quickly because there is a lot to cover, and I want to leave time for questions at the end. We won't be using the chat function today. And before
the leader has muted your line. To unmute your line, press #6.
This call is being recorded and will be posted to the Telligen SURS and QIO websites. These websites can be found on one of the last slides. The slides will be posted within the next 24 hours. The presentation, the recording usually is a few days later. I'm going to mute everyone's line to avoid unnecessary background noise, but I would greatly appreciate you just going ahead right now and muting your own line. That way, when I open the line for questions, we won't have the background interference. Now, following our discussion today, you'll receive a survey that we kindly ask you to complete for us. It really is short, shouldn't take you more than 3 or 4 minutes, and we really value the information and feedback that you guys provide to us. So again, thank you for joining us today. Thank you for supporting Telligen and your commitment to the Quality Payment Program. For those of you not familiar with us, Michelle and I work for Telligen in the West Des Moines headquarters office. We work closely together on 2 separate support contracts funded by CMS and Medicare to provide no-cost technical assistance, resources, and support for eligible clinicians and their organizations participating in the Quality Payment Program. Now, my team and I are QI advisors on the QIO, or Quality Improvement Organization. We serve as support contractors for all of Colorado, Iowa, and Illinois eligible clinicians, especially those in larger practices, systems, and ACOs. Michelle and her team, they're on our SURS contract focusing on the small, underserved, and rural folks with 15 or fewer clinicians in Iowa, Nebraska, North Dakota, and South Dakota. Now, if you are joining us from another state today, welcome. We are glad to have you. If you have any questions on how to connect with your support contractors in your state, we would be happy to connect. Just send us an email. Okay, I'm going to try and get these lines muted.
The leader has unmuted your line.
So after whittling through the 1,500 pages of the NPRM that was released in late July, the doubts and the conversations about what was going to happen with the Quality Payment Program with this administration continues to show us they are moving forward and MIPS is continuing to ramp up. In full disclosure, like all proposed rules, Michelle and I skim it closely, but we don't try to get down into every little detail because it's just that. It's a proposed rule. What's written in this document may not necessarily be what will change for 2019 performance year and the 2021 payment year. Now, the content of this presentation is our interpretation of key changes to the proposed rule and certainly does not include everything outlined in the rule itself. Okay, again, I'm going to ask you guys to mute your lines. And I'm going to try one more time to mute them from our end here.
The leader has muted your line. To unmute your line, press #6.
2019 quality reporting, including, but not necessarily in this order, the pertinent details on how MIPS reporting, scoring, and performance thresholds in 2019 differ from the prior years, how CMS is changing measures with a special focus on interoperability, exploring new ways to participate in advanced APMs, and how to qualify for them. we want to alert you to things to start thinking about for your practices for 2019, as we are more than halfway through the 2018 calendar year. We also want to alert you to things you might want to comment on. A 60-day comment period follows Medicare publications of rules, allowing you to comment on things you feel strongly about. Now, this is either positively or negatively. If you really like something, you think it's good, it really is nice for you to comment on that. I recommend that you do, because it helps to keep that in the rule. Otherwise, those are things that they may just pull out. So don't only comment on things that you don't like, comment on things that you really like and find beneficial. So while I'm talking about comment period, let's address how to do this. CMS does want to hear from you. There are multiple ways to comment on the proposed rule that are listed here. My favorite way is electronically via the direct link that I provided, or you can go into the regulations.gov and you can search for the rule, the proposed rulemaking itself. Otherwise, just use that direct link. The comments need to be submitted by September 10th at 5 p.m. There is a resource page at the end of this presentation that has links to several things that we're referencing today, especially including the notice of proposed rulemaking. Okay, so moving on to start with our presentation, we're going to start with what's staying the same. This is just, an overview of what's staying the same. It's fundamentally the structure is staying the same. There's no big surprises overall. The timeline remains consistent with a performance period January through December. The reporting period that you'll report will be January through March of 2020. They intend to align the due dates for all of the quality reporting programs over time. This includes the web interface, which had a different reporting period the last 2 years. The payment adjustment begins January 1st, 2021. That's consistent. The performance periods, quality, and cost categories are consistent at 12 months a full calendar year, where the improvement activities and promoting interoperability categories are your option to use from a 90-day to 365-day reporting period. The types of exemption remains consistent. Those newly enrolled in Medicare are automatically exempt. If you meet the below the low volume threshold, you're exempt, though they have added a new threshold component. We'll talk about that in a few minutes. And then if you're significantly participating in advanced APM as a QP, then you are exempt from participating. So what's changing? A priority for year 3, CMS is committed to reducing clinician burden even more. They are implementing the Meaningful Use Measures Initiative. They're promoting interoperability program. They're continuing to support the small and rural practices. They're empowering patients through the Patients Over Paper initiative, and they're promoting price transparency. You see a glance of each one of those initiatives, each one of those types of work in the notice of proposed rulemaking. And as we go over some of the pertinent details, you want to keep in mind the caveat to this presentation today is this is only proposed, so this is not set in stone. After CMS reviews your comments, we can expect the final rule to be released around November 1st, which I know isn't going to give you much to get prepared. So, 2019 is the first year we've seen new eligible clinicians added. This is going to be very impactful to certain organizations that have these new type of clinicians. The left table is the current list of eligible clinicians, and that remains consistent with the addition of certain role types that are in the table on the right. The physical therapist, the occupational therapist, and the clinical social worker, and the clinical psychologist are all now added into the eligible clinician mix. CMS proposes to keep the low volume threshold for the dollar amount and the number of Medicare beneficiaries the same for 2019 that it is currently this year. They've also included a third component of the low volume determination, and that's for those providing equal to or greater than 200 covered professional services to Part B enrolled individuals. So this is lines of service. So if if an EC sees like one patient multiple times, if you're looking at beneficiary counts, that patient only counts one. But that one patient, you see them multiple times and they perform multiple services. Those services count each time, and so it will be easier to hit greater than 200. And if it's less than 200, you are excluded or exempt from MIPS. If it's greater than 200, you have an opportunity to opt in. And that's new in this proposal, is the opportunity to opt in. And this would apply for groups or clinicians as individuals. So you have to meet or exceed one or two, but not all three of the low volume threshold. So if you qualify for low volume threshold because you have less than 90,000 in Medicare Part B, but you have over 200 Medicare Part B patients and you have over 200 Medicare Part B services, then you have the opportunity to opt in. However, if you qualify for low threshold because you have less than 90,000, you have less than 200 patients, and you have less than 200 services, you do not have the opportunity to opt in, or what I call voluntarily report. Now, the opt-in opportunity allows any clinician or group to opt in if they meet or exceed one or two, but not all, of the low volume criteria. If they hit all three, they have to mandatorily be excluded. So I just explained that in the previous slide too. Now, if a clinician meets the criteria and they want to opt in, they must go into the QPP portal election process and select that. Now, there's going to be more information about this in the final rule, like a deadline and that particular information. That wasn't really mentioned, what the deadline for opting in would be in the proposed rule. However, they did mention that once you do go in and select, then it's irrevocable. So if you say, yes, I want to opt in voluntarily, it makes you applicable for the payment adjustment either positive or negatively, but once you do it, you can't change your mind. So you'll want to think about that pretty deeply. APM entities interested will use APM scoring standard, and they must do with this at the APM entity level. The box on the right are the estimated projections for the third criterion. They really don't expect that third criterion to exclude any more eligible clinicians from MIPS. They really expect that 42,000 more eligible clinicians will have the opportunity to opt in because they do meet the over 200 services. They also expect 19,000 will have the opportunity to opt in with either meeting the number of patients or the number of Medicare dollars. So hopefully this helps those that have been wanting to voluntarily report the past 2 years. Now, another means of reducing the burden is they want to align all the determination periods. This will happen sooner or later. It may not happen with all of them with the Year 3 rule, but for all the determination periods of eligibility and special status, for those mentioned on this slide, they would all use for the first determination period to be October 1st, 2017 to September 30th, 2018. And the second determination period will be October 1st, 2018 to September 30th, 2019. Now, the rule still goes if you qualify for low volume threshold exemption and that first determination period that you don't the second determination period, you still qualify for the low volume threshold determination period, low volume threshold determination. Okay, so that doesn't change, just the period date. We also see a continuation of support for the small practices with the following flexibilities. They're retaining the hardship exception for clinicians in small practices under the promoting interoperability category, and they're expanding that obviously to include the new clinician types. They're continuing to have a small practice bonus, but they're incorporated into the quality performance category score instead of the standalone bonus to the final score, and we'll talk a little bit about that when we talk about the quality category. They're also awarding small practices 3 points for the quality measures that don't meet the data completeness requirement, And then they're also consolidating the low volume threshold determination periods that we just talked about. So they're continuing to support the small practices. Now this is just a note or an asterisk slide. CMS is introducing some new terminology in the proposed rule. I wouldn't really rush out to change your lingo or do anything aggressive to learn this until we see if it's approved. There's really no operational purpose behind it. It's kind of like last year when they changed some of the language of some of the scoring. So let's move on to the performance categories. Proposed for 2019, the improvement activity and promoting interoperability remain the same at 15 and 25% category weights respectively. The cost category moves up to 15%, which is slower, and which is a slower, more steady increase than the jump to 30% that was originally planned. Again, the cost took over a portion of the quality category, so it reduced it to 45%. Starting with the quality category, let's talk about what remains stable and some of the pertinent changes of each of the performance categories. Okay, so the quality structure is relatively stable. It is influenced by the Meaningful Use Measure Initiative. You still submit 6 measures, including 1 outcome or high priority, or you can still use the CMS web interface for the larger groups. You will still receive 1 to 10 points per measure, depending on the classification of that measure and if it met benchmarks and data criteria. There's still a 12-month performance period, still a 60% data completeness requirement. You also have the same submission mechanism options. Those are now called submission types. So there are some new restrictions and some added flexibilities with the submission types that we'll talk about. For quality, the performance weight shifts to 45%, again, to accommodate the increase in the cost category. They've also included some new reweighting criteria. If an eligible clinician joins a 10 during the final 3 months of the performance period, they've added 10 new quality measures. And if you want to look at those quality measures, they're on Appendix 1, Table Group A, which is pages 1197 to 1207 in the proposed rule. They are 34 measures are being retired. Many of these are popular measures that are being removed. You'll want to look this over carefully. Honestly, these are things that you might want to make comments about because they are some of the popular ones that some of you folks maybe have been using to submit. I really didn't look into these measures with great detail yet, but definitely noticed that some of them were quite, some I've seen a lot of my practices using. There are some sweeping changes to the web interface. There are 15 measures currently. They are proposing to move that down to less than 10. You see on this table the 6 that they are proposing for removal. They are also looking at extending the web interface option to groups of 16 or greater, even having a subset of less measures for groups of 16 to 24 ECs. This is really a nice way to do data abstraction of charts for organizations that maybe have difficult time getting their reports out of their EHR for quality. Or maybe it's cost prohibitive for you to have someone come in and try to data mine their measures. So definitely this is an area, if you have 16 eligible clinicians and you think you're going to want to submit quality through the web interface, something you may want to make a comment on that you really like that proposal. Unfortunately, the web interface measures are pretty much primary care oriented, so it's difficult for large specialist groups to use the web interface measures, but they are talking about web interface measures specifically for specialists. I don't think that will be in the 2019 year, but soon. It's something they're looking at. Other key changes in the quality category include that The claim submission will be limited to clinicians and small practices only. Now, overall claim submission has proven to be the most unreliable and the highest failure rate, but for small practices it may be the most efficient and economical way, and the small practice gets 3 points even if they don't meet the data completeness for that. So they are leaving that in there. They are proposing to leave that in for small practices only. The small practice bonus is now going to be added to quality instead of the final score. CMS doesn't really anticipate that that's going to make a big difference in the scoring. And I really didn't quite understand the concept of moving it to quality instead of the final score, and I'll have to read that in more detail too. Now, if you register for the CAPS, to do the CAPS survey, and you don't meet the CAPS case minimum, they'll reduce it to only needing to do 5 measures that are required, and they'll reduce your denominator from 60 to 50. And they also, in another example of increasing the flexibility for clinicians, and the one that you folks were asking for last year was the ability to submit measures from multiple mechanisms. And CMS will score across all the mechanisms. So those data submission types. Most of the bonus points are staying the same for now, other than the small practice bonus being applied to a quality category versus a final score. And again, CMS doesn't anticipate this will affect the scoring much. So remaining the same are 2 points for outcome and patient experience. This is extra outcome, the bonus points. 1 point for other high priority measures, that's capped at 10% of the quality category score. And 1 point for each measure submitted electronically end to end, again capped at 10%. So what's the facility-based measure that they've talked about last year, and who's eligible for this option? They're the proposed rule intends to implement the facility-based scoring. Many facility-based clinician groups believe that their performance will be better assessed in the context of the facility at which they work. To gain experience with this scoring method, CMS is moving forward with implementing a facility-based scoring mechanism for the 2019 MIPS performance period. And this will align with the hospital value-based purchasing of the HVBP program. And hopefully this will reduce some burden to clinicians. Facility-based scoring would be available only for facility-based clinicians who have at least 75% of their covered professional services supplied in the inpatient hospital, outpatient hospital, or emergency department setting. All clinicians, groups, or virtual groups, regardless of the specialty, can participate in the facility-based scoring if they meet the facility-based definition of the 75%. Now, clinicians will be measured based on a single hospital as identified by their clinician, the clinician that saw the most number of Medicare beneficiaries. So if you participate with several hospitals, you would be measured by only one of the hospital value-based purchasing. There is some this is a little convoluted because the hospital value-based purchasing reporting period, performance period, not reporting period, but performance period is a little bit different than the MIPS performance period, so there's some convolution there that I haven't quite figured out yet. And it's also my understanding that the TIN or the MPI must make an effort to participate in MIPS and submit, do some other MIPS submissions. And CMS will automatically look at HVBP if you qualify, and then they'll score you with whichever score is best they'll give you for the quality category. Now, if an attributed hospital does not have a facility score for the year, the MPI or the TIN must participate in MIPS another method, or you're going to get a negative payment adjustment. So either way, you need to be prepared to do some MIPS submission. So moving on to the improvement activity category. This category is fairly stable. There are no changes to the scoring methodology. The reporting period remains the same with the year option of 90 to 365 days, and the category weight is 15% still. Their minimal changes are the additions or edits to the activities that you'll want to look over closely. They've added 6 new activities. You can see those on the table on the right. They've modified 5 existing activities. There's Table B, Appendix 2IA in the rule that you can look at the modified existing activities. They removed 1 existing activity, participation in the population health research, and they added 1 new criteria that includes a population health emergency as determined by the Secretary that needed to be added. There was a removal of the PI bonus points, but CMS recognizes the need to continue incentivizing for the certified EHR technology, but they did remove by doing an improvement activity through your certified EHR, you're not going to get extra bonus points for that. And I'm really not sure what the reason behind that was. All right. So, moving on to promoting interoperability, which formerly we known it as ACI. I think we're all getting familiar with PI now. This is the category that's changing the most. As a piece of the My Health Data Initiative, CMS is proposing to overhaul the Medicare EHR and SNP program to increase flexibility and reduce burden and promote information sharing. These programs, the EHR and SNP programs, are now called Promoting Interoperability Programs. And in this particular proposed rule, they're making significant changes to the PI performance category requirements to align with the promoting interoperability programs of the old meaningful use EHR and SNP program. We'll start with what remains stable. The weight remains stable at 25% of the final score. They still have to complete an annual security risk analysis. It's still a requirement, even though it's not one of the actual measures. You will need to attest to a security risk assessment. The automatic reweighting scenario is still available for the current MIPS eligible clinician, and it's extended to the additional clinician type. Currently, the structure is based on a combination of 3 categories: the base, performance, and bonus measures. They are proposing to simplify and revamp that structure by eliminating the base, performance, and the bonus scores and proposing a new scoring methodology focused on clinician performance at the individual measure level. They are clearly tightening the flexibility, and systems that have interoperability is a huge focus for this administration, as they are mandating the 2015 certified products for all clinicians. Now, it doesn't say that that has to be the beginning of January 1st, 2019, or if it can be that you have 2015 implemented and you can use it for the last 90 days. Since the PI is a 90-day reporting period, that may be an option. Surprisingly to me, the current statistics indicate that 66% of all MIPS eligible clinicians have already implemented 2015 certified EHR technology. So that's nice. That's great. That will be helpful for you folks as you are moving into that for 2019. The security risk assessment is a minimum requirement. You are not going to receive any points. It's really the sole remaining base measure, and again, there's no score attached to it. Now, the scores for the measures are added up to 100. They add up to 100 points. All measures are mandatory unless there's an exclusion, but there are no specific thresholds for the measures that what we saw early on in the meaningful use is EHR and SNP. Now, if you take an exclusion, they're no longer a free pass. If an exclusion is claimed, the points are reallocated to other measures. So again, they are trying to align this with the hospital critical access hospital, promoting interoperability program requirements, trying to reduce the confusion and the burden for folks. This is a CMS slide. This is, you see a noticeably shorter list of measures. Proposed for 2019 is a complete overhaul of the measure set with a smaller set. You notice that there are 2 bonus measures that they're new and they're pertaining to national opioid crisis, which CMS is trying to target that crisis on a lot of their work and initiatives. Points earned are based on a performance. You no longer have to meet specific base measures before you can move on. There has been lots of concerns, and they're expecting a lot of comments about the removal of some of these measures, such as patient education, secure messaging, view, download, and transmit. They said that this may detract from clinicians' progress on current priorities. However, CMS believes these measures are streamlined, and they really want to focus on those that are most important to clinicians and patients around promoting interoperability. This table, again, is pulled directly from the NPRM. There's only one proposed measure to stay exactly the same, and that's the prescribing. Some measures are retained with modifications and a name change, like the summary care is now going to be called support electronic referral loops by sending health information. You can see the 6 measures that are going to be completely removed or proposed to be completely removed. And then you can see 3 new measures: QIO prescription drug monitoring program, verified opioid treatment agreement, and support electronic referral loops referring and incorporating health information. By the way, it was mentioned in the notice of proposed rulemaking that CMS does not finalize the new scoring methodology. They will maintain the same objectives and requirements as of 2018, except they will discontinue the transition set, and it will just be the one set of measures and objectives you're using for 2018 for the 2015 certified product. All right, most of what you already know about the cost category remains the same, and they're using year 3 to build upon it. It's still derived from claims. There's no special data submission for you. The 2 cost measures are part of the scoring. That's the total per capita cost and the Medicare spending per beneficiary. They're calculating the score that's consistent with the cost achievement points over those that are available, equal the cost percentage score, so that will remain stable. The major key change is the addition of 8 proposed episode-based measures. These will be derived around claims and are based on episode groups. And now episode groups have like certain characteristics, and they're defined around like treatment for a condition, services rendered, aggregation of all items and services provided, and it all is derived again from claims. The 8 new measures include 5 procedural measures with a 10-case minimum, and the attribution to each clinician who renders a trigger service on the claim. There are 3 inpatient medical condition measures with a 20-case minimum, and the attribution to each clinician who bills an episode where the billing 10 renders greater than 30% of the E&M claims line. Here's a list of the 5 procedural and the 3 patient condition proposed episode measures. My first instinct is to think that the new episode measures are a way of bringing the specialist into the cost category equation, because if you look at those in the case minimum, it's going to be really hard for a primary care provider to meet those case minimums, and so they wouldn't even be included in your cost category. So let's talk about cost scoring. For each cost measure attributed to the MIPS eligible clinician, the clinician receives 1 to 10 points based on their performance as compared to the measure's benchmarks. The benchmarks are determined based on cost performance during the performance period. This is all the same. Cost measure to be scored, there's a case minimum of 10 for procedure and 20 for inpatient medical conditions for those episode measures. CMS will not calculate a cost performance category score if the eligible clinician is not attributed any cost measures because of the case minimum requirement or lack of a benchmark. And they're proposing to remove the cost improvement score. Previously, up to 1% was available in the cost category, and they're proposing to just remove that altogether, or at least through 2024, or to 2024. So moving on to scoring and performance thresholds. This is an area you will see ramping up or maturing of the program, I like to think of it as. Personally, I wasn't expecting a substantial jump in the performance threshold. For 2018, you may recall the performance threshold was 15, where you need to get 15 points out of 100 to avoid a negative payment adjustment. For 2019, that's proposed to jump to 30 points out of 100. The exceptional performance bonus pool of $500 million will be distributed among exceptional performers, and it's proposed for that to increase from 70 points to 80 points, and it had been consistent at 70 points for the 2017 and 2018 reporting periods. Now, the penalty increases to a positive or a negative 7%, which is up from the 5% we faced for this year, which, of course, is more complicated than it sounds due to the budget neutrality. And CMS actually did a model budget. They actually modeled budget neutrality, and they talk about that in the proposed rule. They think that you will take into account, various factors. They believe that CMS estimates that $372 million would be redistributed through budget neutrality, and the maximum positive payment adjustments are going to be about 5.6% based on the 2019 performance expectation, and of course that's effective 2021. So this is a bit higher than a bit more substantial than the 2% most of the high exceptional bonus performers received for 2017. They are expecting for 2018 that to be an even higher than the 2%, but they are, their model expects a 5.6% for the 2019 performance period. So this could become a major goal for a lot of clinicians and organizations to incentivize them to become more meaningful and become exceptional performers. I threw this slide in here because it does a good job of showing you the breakdown of the final score points to expect payment adjustment. That's just a nice reference slide for you. How it all comes together, or the calculation to get to the final score, it's similar to the previous years, using the proposed weights, multiplying taking the total amount of points you've achieved, multiplying it by the total weight, adding those together to get your final score, and then using the final score for the payment adjustment. All right, so let's move on to alternative payment models. As part of the QPP, eligible clinicians, they earn 5% Medicare and Medicaid payment in each payment year from 2019 to 2024, and they may be excluded from MIPS reporting requirements and a payment adjustment if they have sufficient participation in an advanced APM and other payer advanced APMs. There's not a lot of significant changes for APMs in this notice of proposed rulemaking, but I don't want you to get this confused with the new Medicare proposed Pathways to Success rule that was just recently released. That rule, CMS plans to overhaul ACOs by encouraging more risk sharing. This proposed rule, this new Pathways to Success rule, calls for the retirement of tracks 1 and 2, and it creates 2 new basic tracks that would gradually increase the amount of performance-based risk for ACOs. Now, I recommend you folks that are in ACOs, you take a look at that rule, and I did provide a link to that on my resource page. This was just recently released, and the comments are due in October. But if you're in an ACO, definitely you'll want to look at this new Pathways to Success rule that CMS just released. Again, not a lot of changes in this QPP Year 3 Notice of Proposed Rulemaking for advanced APMs. They maintain the revenue-based nominal amount standard at 8% through performance year 2024. They implement the old payer option as planned, so that was already in the rule last year that would be implemented in 2019. This old payer combination allows QP status based on a combination of the Medicare APM and offered by other payer APMs. Now, those other payers have to have an agreement with CMS, and once they do an agreement with CMS on this, it's a multi-year. They don't have to get this agreement signed each year. It's a multi-year determination period. Now, also partial QPs, they need to declare and commit to MIPS and doing some MIPS submission. Some key changes for the advanced APMs are the CEHRT usage threshold. It was 50%, has been 50% the last few years. It's proposed to move to 75% of the eligible clinicians are using the certified EHR technology in their APM entity. The other payer advanced APMs must have 75% in 2020, but they get to start at 50% for 2019. They plan to expand the QP determination to include 10-level option. That currently is an individual and APM entity level option for QP determination status, and they want to have that QP determination status to a 10-level status. So between the 10-level status and looking at it that way, and then actually adding the other payer to the opportunity, you may see more QPs, more folks hitting the QP status. All right, kind of rounding this up, let's talk about some key takeaways for scoring. The threshold is increasing from 15 to 30 points. You want to hit the 30 points to avoid a negative payment adjustment. They're increasing the exceptional performance bonus from 70 to 80. Quality is mostly the same with some new flexibility in submission, some new majors. Improvement activities, there's no big changes except some addition and editing of activities. Cost, they're introducing 8 new episode-based majors, probably more specific to specialties, but there's no more improvement and there's no more improvement bonus. Promoting interoperability, this one's the one that's changed the most. There's a new major set with fewer majors, all performance, and it's yes or no majors have been eliminated, and you have to have the 2015 certified EHR product. You have to be using that. It's required. So I wanted to just give you guys a few things that you may, CMS is seeking comments from you folks on. So as you think about your categories, one of the things that they're looking for, the quality category, they want to, they're talking about expanding the web interface core set of measures to include other specialty-specific measures so that there's a specialist could use that. Definitely something you'll want to comment and read about. What should be measured for the opioid-related high-priority measure? That's something they're hoping for comments on. The improvement activity, applying high weighting for improvement activities for those that are employing CEHRT. They're expecting some comments on that. Promoting interoperability, alternative scoring methodology. What do you think about this new scoring methodology versus the base, the performance, and the bonus? And then what do you think about the major selection and the weight for those? In the cost, what about the aggressive increase of 5% until they reach 30% each year? And then expanding the performance period from 1 to 2 or more years. That's something they're also thinking about, that performance period that they would be looking at would be 2 or more years, not just the 1 year. I want to thank you for joining us. I want to go ahead and open up the lines. I'd be happy to entertain any questions you might have. As I said, Michelle and I, we skimmed through this, we whittle our way through it. We certainly don't have all the details that have it all memorized, but I'd be happy to entertain any questions about the content today, and any questions that you may present that I can research and get back to you on. So I do also want to show you, this is the resource page. There's a Year 3 overview fact sheet that's very nice. There's the proposed rule link. Here, the cost performance category, they have put out 2 new fact sheets or resources about the cost performance category, major methodology, a major codes list. And then there's the link to the CMS proposed pathways to success rule. So again, let's open it up for questions. I will open up your lines, and you have self-muted, so if you do have any questions, go ahead and unmute yourself. There's Michelle and my contact information if you would like to submit any questions to us personally. Also, our websites, the presentation recording and slides will be posted to both of those websites in the near future. Do we have any questions? Okay, well, with that being, I am going to give you guys back 10 minutes to your day, and I greatly appreciate your joining us and your commitment to the Quality Payment Program. Thanks.